Sabha, am I audible?
Yes, ma'am, you are. Good evening and welcome all to our today's session. We have with us Dr. Sanitha from the Department of Pharmacology, who will be talking about gram-negative infections. Over to you.
Thank you, Sabha. Good evening, all. Today, my topic is gram-negative infections. So, before going to the presentation class, I would like to thank the organizers and also my team, that is Dr. Danya Sachindran and Mamta. They helped me today for my presentation because I had a urgent like emergency, a hospital emergency at my family. So they prepared the slides for me. So I'm grateful for both of them. So today's presentation is gram-negative infections. Is my slide visible? Hello,
Yes, ma'am. Yes, ma'am. It is visible.
is it in slideshow mode?
It is.
Okay. So gram-negative infection, I hope you all are aware because you are all postgraduates. And like we encounter many gram-negative infections in our clinical practice on a daily basis. So my agenda is basically how gram-positive and gram-negative organisms, basically bacteria, differs from each other, the epidemiology and the clinical impact of gram-negative infections. What are the currently available treatment options for gram-negative pathogens, types of resistant pathogens and mechanism of resistance, and update on treatment options for gram-negative pathogens. So this is the cell wall structure of gram-positive bacteria and gram-negative bacteria. This is the simple diagram. So here you can see this is the structure of cell wall of gram-positive bacteria. So what is very evident is there is a thick blue colored wall around the cell membrane of gram-positive bacteria. And if you see that of a gram-negative bacteria, the that blue colored wall is thin and it is laid between another layer of lipopolysaccharide. So the basic difference between gram-positive bacteria and gram-negative bacteria is the composition of the cell wall. That is, in gram-positive bacteria, the cell wall is a thick structure that is made up of one type of compounds, that is peptidoglycan, while gram-negative bacteria, the cell wall is made up of not only peptidoglycan but also with an outer lipopolysaccharide layer. So when we talk about the gram-positive and gram-negative bacteria, gram-negative bacteria is a little more advanced in their cell wall composition, and hence they are little bit more resistant to treat. So the same diagram is depicted here. So here you can see the cell membrane and outer peptidoglycan layer that is thick for gram-positive bacteria. And here for gram-negative bacteria, the peptidoglycan layer is sandwiched between an outer layer of lipopolysaccharide and lipoprotein and the cell membrane. So it's the same diagram. So if I simply say how the structure of gram-negative bacteria, cell wall of gram-negative bacteria is like, I would compare it with a castle. So outside there is a ditch, that is periplasm space, and there are crocodiles there. So if you see there are multiple layers of protective walls around the gram-negative bacteria, and there are specialized enzymes which are responsible for cleaving and destroying any foreign substance which are dangerous to the bacteria, that is antibiotics. So here there are beta-lactamase enzymes that are present in the periplasmic space that will destroy beta-lactam antibiotics if it managed to enter the narrow porine channels that is present in the lipopolysaccharide layer. So the target of beta-lactam antibiotics is penicillin binding protein or transpeptidase enzyme. They are well protected in the cell membrane of gram-negative bacteria by peptidoglycan layer, outer lipopolysaccharide layer, and beta-lactamase enzyme, even though the beta-lactam antibiotic is successful in entering the periplasmic space. So that explains why it is why most of the antibiotics doesn't work for gram-negative bacteria. So coming to the epidemiology, like if you see the hospital infections, majority of hospital infections are due to the gram-negative bacteria. So this is a study that is EPIC study, that is extended prevalence of infection in intensive care, that was done in 3 parts. So in second and third study, the incidence of gram-negative infection is high compared to the gram-positive organism, that is around 67%, and majority of ICU infections are due to gram-negative bacteria. So gram-negative microorganisms were, like if you just see the statistics, it's isolated in 57% of patients with culture-positive infections occurred in the community. and 71% of the patients from healthcare associated infections, and 78% of from that 78% of patients uh, who acquired symptoms from ICU, they are mainly gram-negative infections. And if you see the geographical distribution also, in almost all parts of the world, gram-negative infections dominates over the gram-positive infections. And the common organisms were Klebsiella, E. coli, Pseudomonas, and Acinetobacter species. So this is the table that I took from EPIC 3 study. So if you see here, 67%, like if you see, it's almost above like 60% all over the world. That is due to gram-negative infection. And if you see, the common organisms are Klebsiella, E. coli, Pseudomonas, Acinetobacter, Enterobacter, etc. But if you see the proportion of resistant organisms, it's not very uncommon. Like out of 18.5%, 9.5% is due to uh, uh, Klebsiella species that are resistant to beta-lactams and carbapenems. And if you see here, E. coli 4.5% out of 17.2% is it's resistant to cephalosporins and carbapenems. And likewise for all the organisms. Like if you see Acinetobacter, it's 8 out of 11.4%, it's resistant to carbapenems. So drug resistance is not uncommon in gram-negative bacteria. And this is a simple diagram representing the narrow, broad spectrum and extended spectrum antibiotics. So if you see the antibiotics which cover the gram-negative bacteria, it's like penicillins, the extended spectrum penicillins, then cephalosporins, that is third generation and fourth generation, sulfonamides, quinolones, carbapenems, then aminoglycosides, tetracyclines, which is broad spectrum, which cover gram-negative bacteria, and polymyxin antibiotic. So it's the same diagram. So the gram-negative bacteria, the common ones, that is Diplococci or Neisseria moraxella, then the enterobacteria, that is the bacilli, Haemophilus, Pseudomonas. So for these organisms, if you see, the aminoglycosides are the commonly used antibiotic. And because we can use tetracyclines, macrolides, fluoroquinolones, carbapenems, etc. for gram-negative organisms. And if you see anaerobes, there is Villanella species, bacteroids, Fusobacterium, Pasteurella, for which clindamycin and metronidazole is efficient. So the gram-negative infections, the E. coli, that's the Enterobacter family, Klebsiella, Enterobacter, Salmonella family, is known to cause UTI, ventilator-associated pneumonia, wound infection, biliary tract infection, septicemia, for which the common modality of treatment is the antibiotics that are third generation, fourth generation cephalosporins, aminoglycosides, fluoroquinolones, piperacillin tazobactam combination, carbapenem, that is imipenem, then sulfonamide, that is trimethoprim, and Pseudomonas, aminoglycosides, ciprofloxacin, piperacillin tazobactam, imipenem. So it's known for causing pneumonia, catheter-associated infection, septicemia, bronchiectasis, chronic leg ulcers, etc. And anaerobic infections, it can cause anaerobic bacteria, it can cause intraabdominal infections, soft tissue infections. Then metronidazole is the main modality for treating bacteria which are anaerobes. Then we can use piperacillin, tazobactam, clindamycin, imipenem for treatment of anaerobic infections. So this is a chart that I took from net. So this is a mnemonic for covering the antibiotics covering the gram-negative bacteria. There is noni, nine. That is no for quinolones, aminoglycosides, monobactam. So the same monobactam is here also, that is astrionum. So ni, that is carbapenems, and ins, piperacillin, ticarcillin, cephalosporins, and polymyxins. So these are the antibiotics which are conventionally used to cover the gram-negative bacteria. So this is a chart displaying table displaying the various antibiotics that are commonly used for treating gram-negative infections, especially in different organisms. So here we have ceftazidime, which inhibit the ceftazidime is a cephalosporin beta-lactam antibiotic, which inhibit the cell wall synthesis. Then there is fourth generation cefepime, which is also a cephalosporin which inhibits cell wall synthesis. Then there is piperacillin tazobactam, that is uridopenicillin beta-lactam combination, that is again cell wall synthesis inhibition. Then carbapenems, there is meropenem and imipenem, which is again cell wall synthesis inhibitor. So these are the beta-lactam antibiotics. And astrionum, that is also a beta-lactam antibiotic which inhibits cell wall synthesis. Then there is aminoglycosides, which inhibit 30S ribosome. And there is colistin, which damages the cell membrane of gram-negative organism. So these antibiotics are effective for Pseudomonas. All of them are effective for Pseudomonas, but for extended spectrum beta-lactamases, like aminoglycosides, carbapenems, and colistin is active. Then for Acinetobacter, astrionum is not effective, aminoglycosides is not effective. So these are the side effects, like common side effects of these antibiotics. So you are all aware of the nephrotoxicity, ototoxicity associated with aminoglycosides and colistin. And colistin, there is neurotoxicity. So coming to the mechanism of resistance, up to 75% of symptoms causing hospitalization, they are resistant to first-line antimicrobial therapy. And resistance is associated with increased morbidity, mortality, and healthcare costs. So there is a recent dramatic increase in extended spectrum beta-lactamase producing Enterobacteriaceae, and there is carbapenem resistant Enterobacteriaceae, and carbapenems are ultimatum for the treatment of gram-negative infection. So we are now facing resistance with carbapenem also. Then there is multi-drug resistant Pseudomonas aeruginosa and Acinetobacter baumannii. So these are the different mechanisms for bacterial resistance in gram-negative organisms. So if you see here, this is a gram-negative bacilli. This is the cell wall, cell membrane, cytoplasm, and the DNA, chromosomal DNA. So here, if you see here, like bacteria can express efflux pumps for spitting out the antibiotic which managed to enter through the porin channels. So there can be mutations in porin channels which lead to porin could be mutations in the overexpression of efflux pumps that will lead to the spitting out of antibiotic from the bacterial cytoplasm, and there can be expression of enzymes that will destroy the antibiotic. For example, aminoglycosides, there is expression of methyl transferases by gram-negative bacteria that induces antibiotic modification for aminoglycosides, which make them inactive. Then the DNA gyrase enzyme, its structure can get altered, so quinolones quinolones are no longer effective. And for beta-lactam antibiotics, there is beta-lactamase enzyme. So this beta-lactamase enzyme can be acquired by plasmid or by expression of chromosomal genes. So this beta-lactamases will destroy the beta-lactam antibiotics that manage to enter the periplasmic space. And for polymyxin, its target is lipopolysaccharide layer. So if mutations happens, that will lead to polymyxin resistance. So these are the various bacteria and their common antibiotics to which they develop resistance. And these are the major mechanism of resistance. So if you see Enterobacteriaceae, they are resistant to third and fourth generation cephalosporins. That is due to the expression of ESBL and AMC beta-lactamase expression. Carbapenem resistance is due to the expression of carbapenemases enzyme. Fluoroquinolone resistance is due to the mutations in DNA gyrase and topoisomerase enzyme. The aminoglycoside resistance is due to aminoglycoside modifying enzymes. So if you see, this resistance is common for Pseudomonas aeruginosa and Acinetobacter species. So, as I already said, the various mechanisms of resistance is impaired permeability, that is due to the absence of pouring channels or due to the presence of efflux pumps. Then it could be due to the change in the drug targets. There can be alteration in the shape of penicillin binding proteins. So the beta lactams can no longer like come and bind to the penicillin binding protein, for example, methicillin resistance. Then presence of enzymes with the ability to inactivate the antibiotics, that is beta lactamases. Then for Pseudomonas, there is biofilm formation that will prevent the entry of antibiotics to the core of Pseudomonas. So carbapenem resistance is a pivotal event in the generation of extremely drug-resistant pathogen. So Enterobacteriaceae with Klebsiella, Pseudomonas aeruginosa, Acinetobacter baumannii, they have carbapenemase variants. So that is a thing of concern. So you all would have heard about New Delhi variant metallo beta lactamase, that is type B ambler classification of beta lactamases that can cleave all the beta lactam antibiotics. So this is a classification for beta lactamases enzyme, that is ambler classification. So there is A, B, C, D. So if you see here, New Delhi variant is type B, and type B and type D is like most of the beta lactamase inhibitors won't work for type B and type D beta lactamase enzymes. So if you see, type A can destroy ampicillin, like third generation cephalosporin and extended spectrum cephalosporins. Type B is notorious. It can destroy all the beta lactam antibiotics. Type C, third generation cephalosporins and cefamycins. Then type D can destroy carbapenems. So if you see, Enterobacteria harbors all the four types of beta lactamases, which is really a concern. And there is Klebsiella pneumonia carbamase 2, that is the most prevalent carbamase that is there in the world, and it can hydrolyze beta lactamase, even beta lactamase inhibitors. So clavulanic acid, sulbactam, tazobactam combination is worthless in presence of KPC2 beta lactamase. So currently available treatment options are like penicillin, cephalosporins, carbapenems, then aminoglycosides. So these are used to treat a variety of illness like sepsis to urinary tract infections. So they have a good safety profile, and there is flexibility in dosing. But the current problem, although they are the backbone, now we have various strains which are resistant to beta-lactam antimicrobials. So in that class, Astrionum has special value because it's effective for gram-negative bacilli, including Pseudomonas. And these are issues with aztreonam, although it's a good antibiotic for gram-negative bacilli. That is, it can we should be careful when we use aztreonam with anticoagulants, which can increase the prothrombin time. Then it's useful for nosocomial infection, intra-abdominal infections, gram-negative septicemia, UTI, skin structure infections, etc. And it can be also used as an inhalation form for respiratory infections. Then tigecycline, that is a synthetic derivative of minocycline. It's a glycyl cycline similar to tetracycline. So its advantage, we can use it for tetracycline resistant organism, and it is also effective for methicillin resistant staph aureus, which is a gram-positive organism. Then it is useful for vancomycin resistant enterococci as well as penicillin resistant pneumococci. It's a bacteriostatic agent with similar mechanism of action of tetracycline, that is, it binds to 30S ribosomal unit and inhibit protein synthesis. So its severe side effect is acute pancreatitis. Can be used in skin and soft tissue, and soft tissue infections, intra-abdominal infections, community-acquired pneumonia, etc. Then currently available beta-lactamase inhibitors are clavulanic acid, sulbactam, tazobactam, avibactam, relebactam, etc. So these beta-lactamase inhibitors, they are effective for class A and class C beta-lactamases, but they don't have much effect for class D and class B. So avibactam, it's a newer beta-lactamase inhibitor, which is which can inhibit A and C beta-lactamases, but it's not effective for class B and class D. But this class B disadvantage we can overcome when it is combined with aztreonam, because aztreonam is sensitive to actually resistant to class B beta-lactamases. So here are the newer options. So we have a combination, that is ceftazidime avibactam combination, that is for KPC, that is Klebsiella pneumoniae carbomesis, and class D, that is oxa type carbomesis. And there is meropenem vaborbactam, that is meropenem is carbapenem with vaborbactam. It's a newer beta-lactamase inhibitor that is effective for KPC producers. Then there is ceftolozane tazobactam combination, that is a second generation cephalosporin with beta-lactamase inhibitor, that is for carbapenem resistant Pseudomonas aeruginosa. Then there is plasmomycin, that is a newer aminoglycoside with better pharmacokinetic profile and lesser toxicity, that is useful for multi-drug resistant gram-negative organism. Then eravacycline, that is a tetracycline that is useful for carbapenem resistant Acinetobacter humani infections. So plasmomycin, it's an aminoglycoside antibiotic which is useful for complicated urinary tract infections, and the spectrum is gram-negative spectrum, that is Enterobacteriaceae. Then its mechanism of action, it's an aminoglycoside, so it binds to 30S ribosomal subunit. It's a protein synthesis inhibitor, and it exerts concentration dependent killing. That means higher the concentration above the minimum inhibitory concentration, better will be the bactericidal property. Then eravacycline, it's a tetracycline antibiotic. It is effective for gram-negative bacteria, which Enterobacteriaceae, which harbors extended spectrum beta-lactamases and carbapenemases. And it is effective for tetracycline resistant Enterobacteriaceae. Then the side effects, just like tetracycline, it can inhibit the bone growth. It can cause super infection, that is Clostridium difficile associated diarrhea. Then there is cefiderocol, that is a cephalosporin antibiotic, which is approved for complicated urinary tract infection, uh, including pyelonephritis, hospital-acquired bacterial pneumonia, and ventilator-associated bacterial pneumonia. So it's a cephalosporin, and its specialty is this antibiotic is taken up by the bacteria using siderophore ion uptake mechanism, which is used for the bacteria to uptake extracellular free iron. Then there is meropenem vaporbactam. Meropenem is an old compound, but this combination is newly approved for chronic UTI, including pyelonephritis, Klebsiella pneumonia, and Enterobacter induce infections. Enterobacter infections. So, future treatment options, there is a new class of antibiotic, that is the prototype is muripavidine, that is outer membrane targeting antibiotic. So it targets the lipopolysaccharide transport protein D, and this drug is effective for Pseudomonas aeruginosa. So that is a newer class of antibiotic for gram-negative infection. Then coming to the treatment of drug-resistant gram-negative bacteria, what we advocate is combination therapy. So the preferred empirical choice for carbapenem-resistant Enterobacteriaceae is, that is ceftazidime avibactam or meropenem vaporbactam combination therapy. So this is preferred, especially when there is evidence for Klebsiella pneumonia, carbapenemase or oxacarbapenemase reported locally, or otherwise we can go for olden drug, novel drug combination, that is olden drug means colistin, polymyxin B, tigecycline, aminoglycosides, phosphomycin, along with or in combination with the plasmomycin, alone or in combination with novel agents, that is plasmomycin, ervacycline, double beta-lactam is inhibitor combinations. So that is same for carbapenem resistant Pseudomonas aeruginosa, that is ceftolozane tazobactam combination or ceftazidime avibactam, and always combine it with an anti-pseudomonal aminoglycoside polymyxin or phosphomycin. If there is evidence for carbapenemases, otherwise we can go for combination with colistin, polymyxin B, aminoglycoside, phosphomycin, or novel agents like plasmomycin, beta-lactamase inhibitor combination. So for Acinetobacter infection, here polymyxin is the backbone agent. It can be combined with carbapenems, aminoglycosides, tigecycline, phosphomycin, rifampin, or novel agents like plasmomycin or ervacycline. So antibiotic stewardship, we have to anticipate, determine, optimize, and consider. So we have to see not only the bacteria and antibiotic, we have to see the host also. We have to see the pharmacokinetic parameters of the host, that is whether there is any renal dysfunction, there is problem with hepatic clearance, what about the volume of distribution, that also we have to see while dosing this antimicrobial agents, because most of them have side effects and problems with clearance because they are eliminated through renal route. Then we have to see the minimum inhibitory concentration of target pathogens, and we have to optimize with maximum tolerated doses, and we have to achieve the plasma concentration using altered infusion techniques, like if the antibiotic follows time dependent killing, that is the time period it depends, the maximum antibiotic or the antimicrobial killing depends on the time above the minimum inhibitory concentration, then we have to look for prolonged or continuous infusion. Then and always we have to go for combination therapy, especially if there is especially if you are suspecting resistant organisms, and consider the availability of new potent agents. So conclusions, now for gram-negative pathogens, there are multiple mechanisms of resistance to already useful antibiotics. That is a norm now. So we are moving to an era of carbapenem resistance. So we have to uh, look for antibiotic stewardship for efficient and appropriate use of antibiotics. And newer agents are there which can offer real help. And not only antibiotic stewardship, we have to go for adequate infection prevention protocols to reduce the disease burden and prevent outbreak of MDR, XDR organisms. So that's all. Thank you for patient listening.
Thank you, Dr. Sanitha, for your very interesting session. If anybody has any query, kindly speak up or write it in the message box. So I suppose nobody has any doubts on. Thank you so much again for today's session. And before I'd like to end the session, there's this feedback form in the group that's been posted regarding thesis work. I would like all of you all to give your feedbacks on that particular, Google form. So that's it, ma'am. Thank you. Bye-bye, everybody.
Thank you.